think it's already night there. The lecture today is going to be ministered by Dr. Maria Peris-Celda. She did her neurosurgery resident in Spain, finished at 2011, followed by 2 years fellowship at Rotterdam, further training in Albany, and skull-based fellowship in Mayo. She's currently a board-certified neurosurgery associated professor in Mayo Clinic of Rochester and head of the Rotterdam Neurosurgery and ENT Anatomy program. It's a pleasure to have you with us, Doctor.
Thank you very much, Larissa, for your nice introduction, and thank you all of you guys for having me here. I'm going to again share my screen, and I'm going to give about a 35 to 40-minute lecture, if that's okay, just to give some time for questions. And I'm going to talk about the anatomy of the sella and what is beyond the sella. So the unseen anatomy that we know that is there, but we don't necessarily see in pituitary surgery, and extend that to other endonasal surgeries in that area. So I'm going to be talking about the sellar and parasellar space, and also the plenum and the tuberculum area, and all the nice anatomy that we have in there. So this is a tribute to Dr. Roten, as always. He was the greatest mentor I could have, and he really saved thousands of lives and with his teachings. And this is something that there's not a limit of, and Larissa knows that, and she's doing a fantastic job here in the lab. So we are very fortunate to have her here. So this is just to start with the basic anatomy of the nose. This is the midline division of the head. And just to show you the sphenoid sinus that is in the center, basically, of the skull base. And it can be differently pneumatized. So we can have the sellar type of sinus. That is this one, that the pneumatization goes behind and below the sella. And we can have also, that's the most common type. And then we can have the presellar type of sinus, in which the pneumatization gets to this area here. So we don't really see very well the recesses of the sphenoid sinus, but we see some of them. And in very few cases, we still have like a non-pneumatized sinus. And those are the most difficult to operate on from the nose, because you have to go through a lot of bone to get to the structures. But I have to say that when we encounter that, the bone is really cancellous bone like this. So then you follow after the first cortical layer, you follow the cancellous bone, and then you find again the cortical bone when you get to the structures. But still, you need to have knowledge of the anatomy, and also neuronavigation there is very useful. But in most of the cases, we fortunately have the recesses of the sphenoid sinus present, and sometimes we have a variation like pneumatization of the superior aspect of the ethmoid towards the sphenoid sinus, and that's shown in this slide, and this is called an onotic cell. So the onotic cell is the most posterior ethmoid cell that sometimes gets pneumatized over the sphenoid sinus. And that's important because then we are not going to see the recesses within the sphenoid sinus. We also are going to be have the recesses of the optic nerve and sometimes the carotid in the ethmoid sinus. So we need to know that before the surgery. In the preoperative CT scan, it's easy to look at. And just another view of, so we're going to see the anatomy in different perspectives. So this is an upper view of the skull base. So the anterior skull base, middle skull base, and posterior skull base or posterior fossa. This is the ridge of the sphenoid that ends in the anterior clinoid process. This is the pituitary fossa. And then from anterior to posterior, we have the crista galli cribriform plate. This area that is the flat area called the plenum. We have the limbus of the sphenoid, that is just the anterior aspect between the both optic canals. Then we have the prechiasmatic sulcus that is in between both optic nerve prominences. And then the tuberculum is just the posterior prominence behind the prechiasmatic sulcus. If we look at the bones from posteriorly, we can see the frontal bone. And then the ethmoid bone completing the skull base. This is the cribriform plate, and this is the crista galli. And then this is articulating posteriorly with the sphenoid bone that has the planum. This is again the limbus sphenoidale, the prechiasmatic sulcus, and the tuberculum. This is an anterior view of the sphenoid bone with the lesser wing of the sphenoid, the greater wing of the sphenoid. This is the superior orbital fissure. And if we look at the sphenoid sinus that is just in the center of the sphenoid bone, we can see here the ostium of the sphenoid. And this is actually another cell. So we see this is actually the posterior ethmoid, and this is the sphenoid bone. It's the sphenoid sinus. In another view of the superiorly of the sphenoid bone, we see again the planum, optic canal, and this is the carotid artery that has the cavernous segment, has a posterior bend and an anterior bend, and there's the anterior clinoid is really wrapped around part of the carotid artery in the clinoid segment, and this is the optic canal, and the optic strut will be dividing the optic or separating the optic nerve from the carotid artery. Looking at the optic canal from an endonasal point of view, we have most of, a little bit less than half of it is facing the sphenoid sinus. And then we have, the superior and lateral aspect of the optic canal is the lesser wing of the sphenoid that ends in the anterior clinoid process, and laterally the optic strut. Now we can see that the optic strut is between the carotid and the optic nerve. This is another variation that we should know when doing an endoscopic procedure. Also in open procedures though, that is the middle clinoid process variation. So we have, this is anterior clinoid and the posterior clinoid. So this is the middle clinoid that is present in about a third of the cases, can be usually small, but sometimes it can almost join the anterior clinoid process and is called the kissing clinoids. And sometimes we even have a cortical clinoid ring around the carotid. So that's important if you are going endoscopically to know where you are going to find probably a middle clinoid process, if you have to go a little bit towards the cavernous sinus, and also to know that you cannot break that or try to remove that if it actually forms a ring, because it can hurt the carotid. That's easy to see in a preoperative CT scan. So this is a view of the left nostril. So this is the septum, inferior and middle turbinate. So if you go back, you can see the choana, the arch of the choana here. This is the superior turbinate, and this is the supreme turbinate that is inconstant. So medial to the supreme or the superior turbinate, if we have one, we have the ostium of the sphenoid. And if we perform a posterior ethmoidectomy, we have a really good view of the front of the sphenoid sinus. Whereas if we do not perform a posterior ethmoidectomy, then we have a very small corridor towards the sphenoid sinus. We see the sphenoid sinus ostium bilaterally, and here removing the posterior ethmoid, we really get a good view of the sphenoid sinus ostium. And here, this is the only reference that we can have for midline, that is the rostrum of the sphenoid bone. And everything else can be off midline, and usually is, especially when we look at the sphenoid septations. They usually are off midline, and they usually go to one of the carotids. So this is actually a view of the another onodicell is a very common variation, so it's not very difficult to see. So this is after opening the ethmoid sinus. We actually see the optic nerve and the carotid arteries. And so we need to know if there's another cell, so we know if we can go further or we have to stop, because it's easy to miss. And if you think that there's still sphenoid behind you, then you can get into trouble with the optic nerve or the carotid. So this is the most common way of looking at the sphenoid. Usually has one or two septations, and usually the septations go off to the side. And here we can see they go off to the carotid. about 80% go to the carotid. So never trust the sphenoid septations because they are almost never midline. With a diamond drill, we drill this and we make it flush, so we have a good view of the sphenoid sinus. And then if we go through the recesses and the prominences of the sphenoid sinus, we find the sellar prominence, the optic nerve prominences, and carotid prominences. And then we have three recesses, the tuberculum recess here. The lateral aspect of it is called the medial OCR, but it's not truly a recess per se, but the tuberculum recess is right here. Then we have the lateral opticocarotid recess or lateral OCR, and then the clival recess that is below the sella. From an intracranial point of view, we can see the prechiasmatic sulcus that I mentioned before, and then the limbus and the tuberculum. And the tuberculum is really where the diaphragm of the sella attaches to. And this is the middle clinoid process. So if we put this together, we see that the limbus of the sphenoid is just the superior aspect of, joining the upper part of both optic nerve prominences. The tuberculum recess corresponds intracranially to the tuberculum and the attachment of the diaphragm of the sella. And the prechiasmatic sulcus, which we've seen in the lab, that is very important structure, is not a recess, but is located between the optic nerve prominences. And it corresponds to this area here that we're going to see that is key in endoscopic endonasal approaches. If we find a middle clinoid process, we're going to find it here, just superior to the C shape of the carotid. And it's exactly this area that we see here. So if we have a corticoclinoid ring, for instance, we're going to find its space here. And then what does the lateral OCR is here, and it corresponds to the optic strut. So it would correspond to this structure here. So that's very important because when we do an anterior clinoidectomy intracranially, then we can have a CSF leak just if this is pneumatized, just running through the OCR, which is exactly this space here. So this is a dissection just showing, this is a superior view. This is the pituitary gland, the carotid artery, and the optic nerve. The ophthalmic artery is usually medial in its origin. It's usually medial and towards the sphenoid sinus. And then after taking the anterior clinoid, we see that the base of the anterior clinoid is really the, we can see through the third nerve, which comes here in the oculomotor triangle, which is located, between both, the interclinoid ligament, the anterior petroclinoid fold, and the posterior petroclinoid fold. So if we look at the sphenoid sinus and we remove with the drill the anterior wall of the sphenoid, then we see the dura mater that has one layer towards the cavernous sinus. The periosteal layer is continuous here and towards the other cavernous sinus, but actually the pituitary gland is invested in two layers of pituitary, of meninges, of dura mater. So this is how it looks in real life, and we have the optic nerve prominence. Sometimes it's more visible in one side than the other. This is the lateral opticocarotid recess. This is the tuberculum recess, the sella, the optic prominence, and the clival recess. So for instance, when we see a tumor like this of, this young gentleman with hydrocephalus, we had to put an EVD on, and he collapsed at work. The pituitary labs, where he had hypopituitarism, and we decided to bring him to the OR and do an endoscopic approach first, just because he didn't have any lateral extension. So here we actually exposed the dural part of the prechiasmatic sulcus. This is the one optic nerve, and the other dural, not the optic nerve, but the optic canal. So this is actually working. This is the diaphragm coming here. So the tumor was a little firm, but with patience and just gentle traction and angled endoscopes, we were able to bring it down. And so this is actually some of the last pieces of the tumor, extracted piecemeal. And you can see how the diaphragm starts coming down. So this is actually with a 45-degree endoscope. So you can see that this is a little bit of the pituitary gland left here. So like a thin layer of the pituitary and the diaphragm. And we reconstructed with a free mucosal graft and an inlay graft. So this is the postoperative result here, and he did really well. He did not recover the pituitary function that was lost, but other than that, he did really well, was discharged home. So now we're going to expand a little bit on our approach here and look at other pictures of the pituitary gland. So this is another look at the dura. Just to understand, there's one layer of dura, the periosteal layer, that just covers everything, and then another one that covers just the pituitary. So the pituitary has two layers, and the cavernous sinus just has the layer that is comes towards us, so which is this one. So really the medial wall of the cavernous sinus is only just the layer that laterally invests the pituitary gland. So that's called the meningeal layer. So here another view of that. And this meningeal layer also continues with some ligaments around the carotid artery. So when we look at the cavernous sinus, so this is the right side of the cavernous sinus, this is cavernous carotid, we can see the inferior hypophyseal artery. So if we go posteriorly towards the posterior clinoid that is right here and the dorsum, we have to coagulate and divide this artery that comes from the carotid artery. And we need to be very careful not to pull, because we can avulse that artery and cause a carotid artery injury. So this is a dissection from Dr. Agosti here at the lab, and looking at the cavernous carotid, and then just looking at a general view of the anatomy here, the optic nerve, the ophthalmic artery, and then we have the sixth cranial nerve and V1, and this is the third cranial nerve here in the cavernous sinus. This is also this is a macroscopic picture looking at the same thing. So this is the carotid, this is the carotid, and this is the pituitary gland in place, and then removing the pituitary gland and then the carotid artery, just to look at the anatomy of the cavernous sinus, the third, the sixth cranial nerve, V1, and then here again, the sixth cranial nerve is the only one that is inside the cavernous sinus and is not in the lateral aspect of it. The other nerves are invested in the lateral wall of the cavernous sinus. And this here is V2, just inferior to the cavernous sinus. And all the other, this is the inferolateral trunk that comes also from the carotid artery. So if the tumors go medial and lateral to the carotid, we have to be very careful not to pull too much, because these little arteries are coming from the carotid and we can avulse them. So how to get into the cavernous sinus? So we want to cut just the layer that is over the cavernous sinus to get into the cavernous sinus for a biopsy, for resection of some lesions, or for tumors extending there. So a lot of the times, if the tumors are extending from the pituitary, you don't really have a medial wall of the cavernous sinus because it has been opened by the tumor. But sometimes the lesions are just in the cavernous sinus and you need to open it. So the traditional way to do it is just to perform an incision here that is away from the two layers of the pituitary. It just gets over the anterior layer of the cavernous sinus. But if we go through an alternative route that is here, through the intercavernous sinus that has the two layers already open, then we can actually get here, and we have a special blade that is a 90-degree blade that once we open here in midline and go through the intercavernous sinus, it's a 90-degree blade that just cuts here in the surface towards us, and it has a very protected tip. So you can actually just go there and start cutting by traction. And this is how we can get from the intercavernous sinus all the way to the cavernous sinus and really not even resect the medial wall of the cavernous sinus and just get into that lesion. So this is one of the cases with a biopsy in the cavernous sinus, which had a patient who had a history of lymphoma. This looked like a meningioma, but there was a question whether that would be, extension of the lymphoma or not. So we were requested to perform a biopsy of that lesion. And so we started in midline and just continued with this feather knife that we call, which is the knife that I just told you. So this is going through the intercavernous sinus. That is where these two layers of dura are really separated because there's some venous blood through them. So you just open that and there's going to be venous bleeding. We know that. We put some thrombin gel foam and pressure that stops, and then you can just continue and open your cavernous sinus just as in the dissections and take the sample from that. That was actually a meningioma. So this is a case of a 53-year-old gentleman who had acromegaly, just to show that sometimes, the pituitary, we can have most of the times a really good look at that with the endoscope. So this is opening the dura and removing the tumor. So this is one of the tumors that with gentle traction and dissection, it comes almost in one piece. So some of the times, most of the times in pituitary tumors, they are either, firm or very soft, and then you just suction them and dissect them with the curette. So this one came almost in one piece. And I'm showing these to just stress the importance of looking at, the anatomy and looking at the pituitary, because sometimes even if the patients have hypopituitarism before surgery, even in 15 to 20% of the cases, they can even recover the function with time. So it's very important to preserve the anatomical structures much as we can. So this is after removing the little bit of tumor that was in there still. And this is a good look of the pituitary gland that has been preserved there. And here is taking the medial wall of the cavernous sinus. So just dissecting inferiorly through the two layers of dura through the intercavernous sinus. And just because this is a functioning tumor, we want to take the medial wall of the cavernous sinus. And this is the post-op imaging with the gland really expanded afterwards. That's 3 months post-op. So then this is another case. This is a young patient with 3 times operated Cushing's disease. So here in the imaging, you see that's really in both cavernous sinuses. There's really nothing in the sella. So this is how it looked like in surgery. So we knew that we were going to give radiation after that this was not a curable tumor with surgery, but at least we could get the tumor away from the optic chiasm, get a smaller volume for gamma knife. So this is actually the bulging, the sellar diaphragm. And this is in the cavernous sinus on the right side of the patient, just taking the tumor out. So this is partially in the sella, and this is, I think, the medial wall of the cavernous sinus that was there that we resected. So there's tumor on both cavernous sinuses, and just the medial part has been resected in previous surgeries elsewhere. So this was, as I said, a patient multiple times operated. And so we are going to work. So this is the carotid artery. So you can see the anterior band and the posterior band here. And this is the cartouche to see if we can find the third nerve or it stimulates for third nerve. Sometimes we monitor, in this case, it's the third nerve. And this is the medial wall that we are going to ultimately resect. And just that's going to the left cavernous sinus again. So we don't want to open here because we're not going to find any tumor. We're going to find a really big CSF leak. So we went to both sides and then we resected the cavernous sinus wall. So obviously you have to be very careful with that resection. That's just looking at just removing the last bits of the visible tumor, and that's the carotid artery that can be seen right here. That's looking at the other side and making sure there was a small CSF leak, but we just placed a free mucosal graft. And this is the postoperative result. So we ended up giving gamma knife to both cavernous sinus. I think there's a little bit of residual here, but overall looks better. So this is another tumor, another pituitary tumor, just a classic marked adenoma. And just looking at the initial debulking of the tumor, and just to show you at the end, you're going to see again the pituitary gland when it comes down. And I think it's very easy, especially for the residents, to get used to recognizing the difference between the pituitary gland and the tumor. So this is the folded pituitary gland. It has a different color, has a different consistency. That's just the diaphragm and the pituitary gland here. And then it was reconstructed with a free graft. And that's the pre-op and post-op result. So just going towards the, beyond the sella and what we don't see behind the sella, but is affected by the pituitary gland pathologies and meningiomas around here. So we can see that really the prechiasmatic sulcus, which is this part, gives us access to the supracellular cistern, to the optic chias, to the ACAs, etc. So this is a view, a dissection from Dr. Ghostin, looking at the diaphragm of the sella from the sellar part. And then what if we perform an opening here, not saying that we're going to just open there for the tumors, but just to see what's the key part of the approaches of to the supracellular cisterns. So just between the prechiasmatic, in the prechiasmatic sulcus, we see the optic chias, and then we see an supra and a infrachiasmatic corridor. This is the pituitary stalk, and this is lamina terminalis. So this is another view of the same anatomy without the arachnoid, and we can see the superior hypophyseal branches going to the optic chias, the ACOM and ACAs here. And this is just looking with a 45-degree endoscope, looking at the ACOM complex and the ACAs, the frontal orbital artery, and the optic chias. So this is a picture from Dr. Larissa, where we can see the same anatomy from above, from an intracranial perspective, pituitary stalk, the optic chiasm and the optic nerves, and the olfactory tracts, and the carotid artery. So this is just to illustrate that endoscopic suprachiasmatic approach. And this is a craniopharyngiomas, a patient who had bitemporal hemianopsia, and she's in her 60s with normal pituitary function. So what we did, we wanted to obviously decompress and take out as safely as much tumor as we could. It's very important. So this is the optic chias, this is the pituitary gland, and this is the cyst. So we opened the tuberculum, the part of the planum, and the suprachiasmatic, the prechiasmatic sulcus. So this is we can see that some of the perforating arteries really attached to the cyst. So, and the pituitary stalk is going to be embedded within the tumor. So we talked to her about if we can detach the tumor completely from the optic chiasm and the hypothalamus, that we may just resect the pituitary stalk. But, if we are going to do a subtotal resection, if we don't think that's safe, then we're going to try to preserve the pituitary stalk and hopefully preserve the pituitary function. And that's what we did. So we decompress the cyst and dissect the small the small branches there, and this is after resecting part of the cyst. And just getting, we saw that the part of the capsule was completely stuck to the optic chias. There was a part of the tumor that was solid. And this is taking part of the cyst wall in a piecemeal fashion. And we can see that it's completely attached to the optic chias. And this is just performing some further dissection of this, but at the end that we're going to see that we left part of the what we thought was the pituitary stalk, and then this is reconstructing with a fascia lata bottom graft and an nasoseptal flap, and this is the postoperative result. So this little bit of the the pituitary stalk with a little bit of the capsule, but overall, she's doing very well. Her, her pituitary gland is, function is good, and she has no ODI. So her vision is better. We are just monitoring that tumor there, and if she needs, she'll undergo radiation afterwards. So this is another case just to show you some different pathology that can occur in the sellar and supracellular region. So this is an arachnoid cyst in a 72-year-old gentleman who had baseline no vision on one eye because he had an accident, and then he was losing vision in the other eye, and he went to the ophthalmologist. So he was at this point when we saw him almost completely blind with this really large arachnoid cyst compressing the optic nerves. And his pituitary function was he had pituitary insufficiency, but no diabetes insipidus. So this is exactly where this the structures that this cyst is compressing, and this is looking into the ventricle through the lamina terminalis. So this is the surgery, and we want to fenestrate posteriorly the cyst. So then when we open, there's a lot of obviously CSF that comes, but of course you have to open here and also fenestrate. So you could have fenestrated also from an intracranial approach, of course. We chose this approach. The patient was not in great shape as far as, he had a lot of comorbidities. We thought that it was overall a safer approach for him. So you can see here that this is the pituitary gland that is paper thin. And this is, believe it or not, this is really the pituitary stalk right on the side. So this is part of the capsule of the tumor, of the arachnoid cyst. And we could see the little vessels, and even, here you can see these are the foramen of Monroe. So I thought that was a good video to show this anatomy. So we were looking at the foramen of Monroe here. That's pre-op and that's post-op. He has stable vision. Right now he has an improved vision, but at least he didn't worsen. So this is another example, small growing tumor, patient with normal vision, just to illustrate the anatomy. And a tumor that is growing towards the nose as well. So this is the optic chias, the optic nerve prominences. So this is after we open the dura here. This is the optic canal on one side, on the other side, on the carotid arteries. This is the superior intercavernous sinus, and going towards the, that is in continuation with the diaphragm of the dura. And this is just looking at very often, these patients have, the arachnoid layer here is between, is the outer arachnoid, and a lot of the times is protecting, the structures, the carotid artery, etc. So a lot of the times it's not attached to the vessels in these smaller tumors. And the arachnoid really protects you. So this tumor is going towards the optic canal a little bit, and we want to be very mindful of any traction And this is the feather knife. So this is actually sharp dissection, because this 90-degree tool, it cuts towards the surgeon. So it's a very nice tool for this surgery. And I use it a lot, and instead of the micro scissors even. So you can see here very nicely the optic nerve, and you have to really make sure that you take all the attachment of the tumor. So selection of the cases is very important. And I especially look, this is the ophthalmic artery here. So I especially look at the attachment of the tumor. If I don't think that I can do a good job endoscopically, I just choose an intracranial approach. This is the post-op. And this is, I think, the last tumor, a little bit bigger tumor, but still we thought that could be a good approach with the dural base between both optic nerves and not beyond them. So this is actually a case with a presellar type of sinus. So you don't really see much of the, you don't see a clival recess, but you can see the optic canals right here. And these are the carotid arteries, but still not very clear where the structures are. So this is just drilling above the tuberculum and the planum. This is drilling the tuberculum and taking out the bone here. So if we can drill around and just perform like an osteotomy, that's usually a little faster to do rather than drill everything. So, and this is just drilling to expose the sella. Just drilling the tuberculum. And also opening the optic canal and decompressing. And this is just opening exactly with that tool, which is very useful to open also the dura, and just going around the tumor through the base. And of course, exactly the same as an intracranial approach, just decompressing the tumor, debulking. We can see there's a little bit of rain between the tumor and the ACAs. This is ACOM, A1 on both sides, A2s here. And this is the optic chiasm and the lamina terminalis. So this tumor needed a little bit more debulking. It's a firmer tumor than the one that I showed you before. And then, of course, there's going to be some traction when removing the tumor. And you have to always be mindful that there's going to be some kind of vessel that is feeding the tumor from above. If there's real ACA encasement, I don't usually use the endoscopic approach. But this is the orbitofrontal artery. So you just have to be mindful, because just one of the branches went towards the tumor, but the main branch obviously comes from the ACAs, so you need to be mindful not to avulse it. This is the optic chiasm, and this is the final result. And then we put a fascia lata and then cover with an nasoseptal flap, and that works really well for us. This is the fascia lata, we sutured both layers to 2 layers together. So one is inlay and one is onlay, and then we put a nasoseptal flap over that. So this is the pre-op and post-op result. She did very well. So that's all I wanted to talk about tonight. And, you know, just to summarize, the endoscopic view is complementary of the macroscopic view. And I have to thank all my fellows in the lab, and thanks especially to Larissa for, you know, and all the department for inviting me tonight. Thank you very much, and I'll take any questions.
Thank you very much, Maria, for excellent lecture. And I think this is the first time that I understood something about this anatomy once it's not my expertise field, but it was wonderful. I would like to open to the audience, and I think there are more people here that has more experience than me in this field. So I will open for the audience, then they can ask you some questions if you allow us to.
Sure.
Please. Yeah, I think Elion is here, Rafael, Clayton, Victor, all people who are studying. Dr. Elder is here also. He is the senior one and the most experienced one in skull-based surgery. So we can start with Dr. Elder.
Well, good evening, everybody. Dr. Peris, that was really nice. The anatomy is always, it's always nice to go back to anatomy and always learning. This is a view that I'm not really used to, and usually go from above through the nose. But a lot of people here in the audience have a lot of experience on doing that, and it's always good to have a different view of, I mean, other solutions to different problems. And I think the cases were very, very nice. The anatomy was very interesting from a different point. So I was wondering who did the dissections. Was that from your lab? You have fellows that do the dissections for you?
Yeah, so a lot of them were from the lab, and some of them from Dr. Larissa, and then Dr. Agosti, and then some of them are mine from when I was at Rotons.
Mm-hmm.
So,
you spent some time with Dr.
Yeah, I
Roton.
spent 2 years with Dr. Roton, a long time ago, but I did, yeah.
When was that?
In 2011 to
Okay,
13, I was there 2 years, yeah.
I was there back in 1989, so long before you. But it's okay, really nice. I could see for the quality of the sections, they're really, really nice. Well, I have no comments on that because, as I said, I'm not used to going through the nose, but I think it's a wonderful job. I have some concerns about operating on meningiomas through the nose. And I've heard once that it's a kind of surgery that is more of a pick, pull and pray. I don't know if you think like that. I don't think so. But sometimes when you look at the arteries in the back coming together with the tumor, that is a big concern for me, I think.
I agree. So I think, yeah, I agree. So number one, I think the arteries are a concern. So I think the selection has to be extremely precise.
Mm-hmm.
So none of the cases that I showed had really vascular encasement. If they do, I don't hesitate to do them from above. Some people probably risk a little bit more. I personally don't want to risk when I see that. So that's one. And then the other one, I think the reconstruction technique. So I'm very lucky. I work with a great group of ENTs, skull-based surgeons. One of them, Dr. Pinheiro Neto, he's from Brazil. And yeah, he trained at Pittsburgh and University of Sao Paulo. So he's fantastic at reconstruction. And our leak rate is extremely low. It's about 1%, even for the standard cases. So I think if you don't have a good reconstruction team or a good reconstruction technique, it's much better to do it from above. And I would say, select super selected cases, at least for me, would be super selected cases as far as no vascular encasement and really having the dural base within your reach. If it has dural tail going to the side, I would not say that that's a good case for endoscopic approaches.
Yeah, actually, I have a question. Is how far lateral can you reach through the nose?
So I don't go. So if you look at the optic nerve, anything that is lateral to the optic nerve, I would say to me is out for endoscopic endonasal as far as meningiomas go. Sometimes, so you can go, when you have in the orbit, you can remove the lamina papyracea and push a little bit the periorbital, so you can reach a little bit more lateral, but that's about it. If it goes lateral to the medial part of the optic nerve, I don't think it's a good endoscopic case, because you're going to leave tumor behind.
Yeah. Another thing is that I saw you drilling, and there's not a lot of irrigation. Is that a problem with your assistant, or you don't use that much irrigation? I'm very concerned to canals with that, you know.
Yeah, so we usually use the irrigation at like usually we use the endoscopic Medtronic shaft that has a constant irrigation. It's very, very thin, so you don't see it as readily as you see when you're, you know, drilling the mastoid, or when you're drilling from above, that you can actually see the canal. So it goes through the shaft, so you don't see it as well in the video, but there's a lot of irrigation.
Okay.
In there, yeah, definitely, that's a concern.
Okay, congratulations. That was really nice.
Thank you, Dr. Lateral. It was nice to see you.
Victor.
Yeah, Victor.
I'm sure Victor wants to ask questions.
Congratulations, Dr. Peris. It was a wonderful presentation, wonderful cases. It was very didactic to me. All this anatomy. This is an area that I have a lot of interest in to talk about, and in concerning that anatomy around the cavernous sinus, I saw you showed the inferior hypophyseal artery, all that space that you can create to go through the tumor, or even open to get tumor inside. And my question is, when you need to deal with tumors behind pituitary stalk, pituitary gland, or interpeduncular fossa, what kind of pituitary transposition do you use? Are common to use to you? Is it a hemi transposition, or even a total transposition? Do you usually to coagulate the both inferior hypophyseal artery or not? What do you usually to prefer?
So I usually go, if possible, I usually go through one side. I haven't had to use the total one yet, but I do an intercavernous approach, a transcavernous approach, meaning like leaving the medial wall of the pituitary with the pituitary gland and cutting the inferior hypophyseal artery. I think that's probably like the easier and safest way to do it, to respect the pituitary gland. So that's what I do.
Did you have you ever had any kind of a pituitary dysfunction after coagulating the both inferior hypophyseal artery?
No, I haven't had to coagulate both in a case. So I have usually coagulated just one. So not with that, but of course you have to be mindful. I think that could be a concern. You're right.
Of course. And if I have enough time, I would like to ask you another question, especially for the tumors invading the posterior fossa when we are going through the transclival approach. For example, we have an extension of tumor laterally to the paraclival carotid artery. So in this situation, do you prefer, how can you get there? Do you usually to leave the tumor for another approach, or are you intending to trying to mobilize the carotid artery from to the side to get the tumor through the nose?
So it depends on what the pathology is, and it depends if the pathology is resectable. Sometimes the pathology is just not resectable, and if you can, if it's safer to leave some tumor behind, and we don't take tumor at all costs. So obviously, depend of what the pathology is. For instance, if it's a malignancy and if it's, invading the carotid artery, then you don't want to risk it, because that carotid artery is going to be very frail. So you have to be mindful of that. And if it's, it depends on the consistency of the tumor, if you can do that. It depends on the anatomy of the patient. Overall, it depends on the case, but I try not to expose what I don't need for the operation. And if I cannot take, I want to choose the approach, not that I prefer, but the approach that is going to give me the maximal resection of the tumor in the safest way. If that's an open approach, it's an open approach. If that's an endoscopic approach, an endoscopic approach. And sometimes you can offer the patient both, and usually the patient, if you offer, well, I can take it through the nose the same way I can take it through, an open approach, a lot of the patients would prefer to take it through the nose.
Okay.
But you have to be mindful when you offer some kind of approach that is the approach that you think is going to get the most tumor out and is going to be safer for the patient. And then the other option, if it's not equally safe or good for the tumor resection, I think should be out of the conversation. Because as Dr. Elder said, if there's ACAs wrapped around the meningioma, fibrous meningioma,
Well, for sure, we cannot
very,
remove.
very, very high risk.
Okay. Congratulations for the lecture.
Thank you, Victor. Clayton, Elion, would you like to ask something to Dr. Maria?
Hello, good evening.
Hello.
Thank you very much for the mastery class. I have a question. How is your rationale for this decision-making process about the resection of the medial wall of the cavernous sinus for pituitary adenomas? I mean, some authors had described invasion even when the medial wall looks not invaded on MRI. So how do you decide to do?
So if it's a functioning tumor, I suppose you talk about the functioning.
Yes, yes, GH.
Yeah, so I resect that now. And the reason for that is, so as I showed in the video, if you go between the two layers, if you find the inferior intercavernous sinus, you can actually kind of dissect the two layers in the midline. So what is scary about taking the medial wall of the cavernous sinus is that incision that they described, just a lot on the side of the carotid, just medial to it. I think that's a very risky incision. You can do it 100 times, but maybe one, you're going to have a carotid artery injury. So thankfully, I never experienced that, but I think it's better to operate midline, find the inferior intercavernous sinus, and just start dissecting and opening with that 90-degree knife that I don't have any interest in the company, but it's just very useful. And Mizuho makes them. And Dr. Gardner at UPMC is the one who designed it, and it's really a great tool. So if you go and just, separate the two layers in midline, follow that along, that's the medial wall of the cavernous sinus, and you can take it very, very safely.
You mean the feather blade, right?
Yeah, with the feather blade. It has like a little ball on the tip.
Yeah, sure.
And it just cuts towards you. So, you really can use it for the dissection and then cutting. So you don't have to change instruments.
Sure. Great. Thank you very much. I have another question. And do you think is there any role for the visual evocated potential for pituitary surgery? Do you use it?
Yeah, we use them. It's a little bit experimental at this point, and I haven't seen any intraoperative changes yet that would make me stop or change or do something different. But it gives me some peace of mind just to know that they are stable. But we started recently just monitoring visual evoked potentials probably like a year ago or so. And I don't monitor in every case. I monitor when the patients have poor vision, and sometimes baseline, you cannot find anything because the vision is so poor. But I haven't seen any intraop changes, so I don't know how useful that will be.
Sure. Thank you very much.
You're welcome.
Thank you, Dr. Clayton.
Okay, so
would you like? Yeah, okay.
Yes, I'm ready. So, Dr. Peris-Celda, great lecture, as expected. Give my regards to Dr. Carlos as well, please.
I will.
So one of the questions I had, Dr. Clayton asked already about the medial wall resection, but I think this is very interesting. I think since Dr. Oldfield published the first article about medial wall resection, people start to think about this, but only after Juan Fernandez Miranda, Dr. Miranda, he published, people are doing it. And I think everyone's seeing results. I've been following Cleveland Clinic for some time, since the beginning of my residency, and I saw the pattern change here as well. So now both Dr. Sims and Cachete, we have a functional tumor. It's more lateralized, it's touching the medial wall. We will resect it. And one of these days we did bilateral resection because the tumor basically was, and the patient had biochemical remission. So that's good. But Dr. Peris-Celda, one question. It happened twice with us. We entered thinking it is a pituitary adenoma, but during surgery, firm, and the frozen came as meningioma. Basically, I think a diaphragma meningioma, something like that. Are you guys in Mayo using any kind of imaging to kind of differentiate between those, or is kind of a surprise?
No, not really, no.
Yeah, because kind of changed what we can do in surgery, right? So.
Oh yeah, absolutely. Yeah, absolutely. Then you find a much more fibrous tumor, and then you think you're in the sella, and then it's not really the sella, it's above the sella, so thing changes and you have to use a flap, and yeah.
And another, I saw that you were basically in one of those tumors, you were going to the superior compartment of the cavernous sinus, and you finding 3, and then you talk about IOM, but EMG. This is something that you guys are doing 3, 4, 6 for when you are going. And
not always, depends on the tumor, but we have the capability. So I usually don't go for 4 when I do endoscopic, because it's really rare to find it. I use 3 sometimes when the tumor goes to the roof of the cavernous sinus, and I use 6 when the tumor is really inside the cavernous sinus or it's on the other side of the carotid, and I need to remove tumor from the lateral wall of the carotid a little bit, but not routinely. It's just when the tumors have a large extension to the cavernous sinus. But a lot of the times you can't even have a good response, even if you are on the spot for some reason. But intracranially, I use it more even. So even 4, I use quite.
I think it's the same experience as VEP. We are trying to build something about VEP here as well. But the feeling is the same. We started with a red LED, then we changed to the white, but sometimes the monitoring teams, they say to us, okay, we are not getting, not even the baseline that we want. So
we always
the same
get
thing.
The baseline, they now change to like little white things that have really a theme. So they always get a baseline, but at least on one eye, unless, but sometimes if the vision is very, very poor, there's really nothing. But that's because the vision is very poor, and I don't think they could record anything.
Are you guys still using the goggles or using the
No,
lens?
we're using like little pads that are this thick. So they're like not adhesives, they are a little bit thicker, but not the goggles.
Yeah, I think the same thing, but we are having problem with that as well. It's a research that I was trying to do, but
I don't know how useful that will be.
Agree, totally agree. Yeah. No, but again, thank you so much for the lecture. Really good to see anatomy, these wonderful cases, and regards again to Dr. Carlos.
Thank you. Thank you.
Thank you, Erion. Somebody else want to make some questions to Dr. Maria? Rafael, some of our residents, Dr. Donizetti.
Excuse me, if there is no question, it's possible. I would ask Dr. Peris about the indication of removing these tumors inside cavernous sinus. It's sometimes difficult to deal with tumors when they are not functional tumors, and it's inside cavernous sinus, but it still don't have any symptom. So in this case, sometimes difficult to indicate. What do you think about when is the correct moment to talk about surgery, especially in these patients that usually to be asymptomatic?
So we observe a lot of the tumors. So the absolute indications, as you know, functional tumors, tumors with compression of the optic, chiasm, and visual component. But just because the tumor is incidental and happens to extend to the cavernous sinus, if there are no symptoms, we just watch it. And if they grow, we take them out.
Sometimes the moment the reason of this question is because sometimes it's invading, but it's not involving the nerves and the carotid artery, and it's still growing when you are doing your control, radiological control. So the tumors is invading, sometimes probably after invading the nerves is not be could not be well resected after. So in this case, if you're still seeing it's regrowing, it's growing, and you still don't have any symptom, do you usually to perform surgery?
So it depends. If it's a sellar tumor going to the cavernous sinus, yes, I do surgery first. I see what I can get out safely. Sometimes it's just, attached to the carotid and you cannot take it all. But if you do a good debulking, then the tumor obviously regresses a lot, and especially in the cavernous sinus, and then you do an MRI in 3 months. And a lot of the times we just watch it. And if it continues to grow, then we give gamma knife to that tumor. So like the Cushing patient I talked to you, I presented here, he had, I think was the 3rd surgery, and he had radiation. But then we said, well, we got to the multidisciplinary team. I said, let's do the surgery. Let's see how much we can get out safely, which was a cytoreduction of the tumor. And then we give gamma knife to both cavernous sinus because we assumed that there was some residual there, even microscopic. So,
Okay.
but it was a nearly silent corticotrophic adenoma. So he didn't have many Cushing features, luckily. So.
Thank you.
You're welcome.
Dr. Maria, do you have any experience with fibrous dysplasia, decompressing the optic nerve in fibrous dysplasia?
I didn't have many cases of fibrous dysplasia that I needed to decompress through the nose. We almost had one case that, but she didn't have like any neuropathy, so we ended up doing like a facial remodeling because it was mainly like frontal and all that. But yeah, I mean it's quite bloody, and it's it would be a struggle if there's a lot of tumor. It depends on how much is towards the nose, but it would be really a struggle sometimes with some cases where they have a lot basically in the skull base to go through the nose, because I think it's very difficult to find the optic canal if there's not a good reference. And especially you have the carotid artery right there, a lot more exposed than when you go intracranially, that you can just remove the roof of the orbit and just follow the periorbit and get to the optic canal. I think that's overall a safer way to do it.
So do you think it's safer coming from above?
So it depends on the case. So if you still have the recesses of the sphenoid sinus, when you have not really a lot towards the nose, and then you think you can identify the optic canal, I think it's safe to go through the nose, and it's probably easier for the patient as well. But if there's a lot of dysplastic bone towards the nose, it would be very difficult to get a good anatomy there, and probably very risky. It's easy to get the carotid, I think.
And it's always very difficult to decide when to indicate the surgery, because if you wait, they will have some kind of ischemic changes in the optic nerve, and like Dr. Elder said, just drilling the bone, you can get this patient blind. Right. But if you indicate so early that if the patient doesn't have any visual disturbances, okay. Somebody else want to do some questions? Larissa, do you want to say something to us?
No questions right now. Thank you. Great lecture, Doctor.
Thank you.
If no one is asking, I'll ask one of our curiosity as well. Dr. Peris-Celda, how are you guys managing right now olfactory growth? Of course, we have the patient that does not have infection anymore, but like large tumors, patient with no infection.
So it depends. So it depends on your base of implantation and depends on the ACAs. So if the base of implantation is wider than you would, get with the endoscopic approach, I wouldn't choose the endoscopic approach. If it's a tumor that is, has lost smell and the base of implantation is within, the reach of the endoscopic approach, or some of it goes towards the nose, and there's no ACA encasement, then I would say, we do an endoscopic approach. So for us, there are a lot of conditions to do that through an endoscopic approach, because if there's an alternative that can take the tumor safer or more tumor out, then I prefer to do.
But basically, the tumor decides, right? The tumor will give us...
exactly. So it's a matter of, the base of implantation, I think, is one of the most important. Because if you can do as good of a job with one or the other.
No, good, thanks. I was talking with Larissa this week about the transbasal, and when I think most of the cases right now we're doing transbasal, like bicoronal transbasal. Of course, the type 1. But Dr. Ricinos remove the orbital bar. Dr. Kashetter do more the Dr. Lewis modification, only going down. But we don't go lateral, like anterolateral. That was more our school in Brazil. I think Dr. Tedeschi and Dr. Ghisoni, when we do like an olfactory groove, they would come off anterolateral. And when you go open, you would go more like transbasal or go more anterolateral nowadays?
So it depends. Sometimes if it's, so for instance, there are some patients that have a very high supraorbital cells, and I don't think I can do a good approach just going lateral, because I cannot look at the olfactory groove too well. So then I choose a transbasal approach, and also look at the interhemispheric, like the height of the tumor. If it's very high and it's very large, usually the midline works better for me. But if it has any lateral extension and I need to drill and I need to decompress the optic canal, I do an anterolateral approach.
Okay, thanks so much.
Okay.
Okay. But somebody else want to do another question? Well, Dr. Maria, thank you very much joining us this night, and thank you for sharing with us your expertise and knowledge about this region and about this anatomy. And
thank you very much for the invitation.
No, it's an honor for us, and thank you for taking Larissa with you there. We really like her here.
She's great. So it's a pleasure, really. Thank you very much.
Thank you very much. Thank you.
Have a good night, everyone.
Have a good night.
Bye.
Thank you.
Have a good night.
Good night.
Good night.